relieved when leaning forward. There was loss of appetite, loss of weight. Loss of weight was 10 kilograms per 3 months. He complains of reflux disease and catheters and bloating. There was no steatoria. He used to give salary receipts, and there was no history of fever, no history of previous blood transfusion, bleeding disorders, fractures, and there was no history of
Fractures. Why? Nutritional issues. Are you theoretical?
there's no history of
Have you seen patients having fractures during delivery?
there's no history of trauma to abdomen. He doesn't have any sinister headache, intractable backache, or meningitis. He is asthmatic. He doesn't have diabetes or hypertension, no history of Gallstone disease, no hyperlipidemia or hypercalcemia, no ERCP done before. There's no family history of pancreatic carcinoma. He is not he doesn't have any allergies. He's a smoker, but not alcoholic.
That's good. Examination. But आपको हमारा किस पे? That's fine.
Representatives who episodes of gastric pain for 1 year duration. Sudden onset severe dull pain radiated to back.
Severe dull is too severe dull, isn't it? Can the severe pain be dull?
Radiated to back and last 2 to 5 days. It is associated with nausea and vomiting. Pain relieved by bending forward. 2 episodes for 2 year duration. First episode my exact acute pancreatitis 1 year ago, and second episode 1 month ago. No dehydration, no GI symptoms, no fever, no chills, no.
So, whatever you should tell her, she goes and takes a second pancreatitis. Yeah, was it mild acute, severe acute, or moderate acute? How do you ask this in history? If she says that it was pancreatitis. Yeah, and how many days after she was discharged? If the patient is discharged after 3-4 days, what is it most likely to be? Two, 3 days. Mild acute pancreatitis. But if the patient was managing HDU or ICU, most likely is a illness, Otherwise, there I don't show your knowledge. show your knowledge. Then in the limited time, you have to show your maximum knowledge.
No previous history of blood transfusion, no previous history of chest pain, no previous history of ischemic heart disease, no coke, no pain, mild respiration. She had loss of weight for 9 months duration. She lost 18 kilograms of blood duration. Loss of appetite for same duration. No steatoria. She was not alcoholic. No previous history of no family history of pancreatic carcinoma or snake bite. No previous history of
kata kira
Howling up and flying. Opium. Kamu cuba ni orang kamu. Kalau family sus ni kau
kata kira mesti
mana kau dah lagi kan?
kata tak mesti
Wide away.
gimana gimana
Very difficult patient. Why do you think this patient is coming back? It could be recurrent to actual pancreatitis. Why? CT. Otherwise, it could be recurrent acute pancreatitis. Because there are certain criteria for you to say it's coming. It's a difficult entity, difficult entity. Because unless you can see calcification or external or endocrine failure, we really don't know whether it's recurrent acute pancreatitis or acute chronic pancreatitis. Very difficult. Even today, it's a very difficult diagnosis to make. Unless you see obvious evidence of chronic. We have several patients who come in with recurrent acute pancreatitis but no obvious cause. So we don't know whether they are recurrent acute with no cause, with no obvious cause, or acute and chronic. Where are the features of chronic? Chronicity has not developed yet. We don't know.
Past medical histories was not remarkable, and is also not remarkable. She has undergone low technical cesarean section 17 years ago. Parkinson's or nothing. No family. No family history of any malignancies or severe episodes. Social history-wise, she was previously worked in a company and due to her disease, she was not employed now. Her husband worked in a mine and the income is good and family support also. On examinations, she was well-looking and not in pain and blood compared. After examinations, soft and unremarkable.
The very early late is very early stage. So, what is chronic pancreatitis? Chronic inflammation, chronic irreversible, chronic inflammation of pancreas leading to irreversible parenchymal disruption with element of fibrosis. Okay, irreversible parenchymal disruption with element of fibrosis leading to exocrine and or endocrine failure. Some people have both. Some people have none. Okay. Some people call it a triad. I don't know. Chronic pancreatitis has calcification, external failure, and endocrinal. Generally, they have calcification. But exocrine and endocrine failure, some people have nothing, some people have both, some people have one. It depends on the degree of parenchymal disruption. That is the definition of pancreatitis. What are the causes? Presentation? How is the presentation? How can they present? One is pain. Can be complication of chronic pancreatitis. We'll discuss other complications later. Okay, I'll tell you maybe MS, maybe obstructive jaundice. Diabetes. Exocrine failure. What are the features of exocrine failure? Steatorrhea, loss of weight. But if the patient is diabetic, yes, loss of weight could be due to that. Can be incidental. Those can or abdominal extent something else. Using pancreatitis can be incidental also. अपने सर्जिकल वार्ड में मुकाबले में बदर part में very difficult man. Very difficult man. Most of them have analytic conditions. Very difficult because all these causative factor for pain, they are just hypothesizing things. We don't know. We think some of them have ductal obstruction, some of them have retroperitoneal fibrosis. So many causes. We don't know. Very difficult to address. So in the history, if you get a chronic pancreatitis patient as the exam, it will be abdominal pain patient. Usually we will be giving a straightforward case of epigastric pain. So you have to ask, if you get abdominal pain as a long case, and if they are getting bleeding PR, you know what are the set of questions to ask. Breast lump pe ganna monaad kiyala hanne ganna gani what is it here. This is a difficult case but easy to tackle if you know the technique. You just, if patient says epigastric pain, what are the organ system in this area? Will you think of diverticular disease, urinary colic? No. You will think of either stomach, pancreas, or biliary, or acute hemorrhage. One event is so acute, you will think acute hemorrhage. So those are the differentials you think of. So when you know the organ system, you know what are the questions to ask. Similarly, if you get LIF pain, you will think of diverticular disease and urinary colic. RIF pain, you will think of possible things on that side. So if you get pain, you will think. So these patients, if you go through their history, they have chronic abdominal pain, long standing. Most of them were treated as having gastritis. You know, කාලයක් තිස්සේ මේක තිබ්බා. ගොඩක් ඒවා ඉස්පිරිතාලේ යන ඕනේ නැහැ. ළඟ දොස්තර කෙනෙක් ආව ගියාම gastritis කියලා බෙහෙත් දුන්නා. Classical history. But on and off, they had severe episodes requiring hospitalizations. And when you ask the history, it's a difficult pancreatic type of pain. You have to describe severe pain, radiated back, reduced bladder forward, associated with nausea, vomiting. So those things are there. With a past history of severe pain, they didn't require hospital admissions, treated as having gastritis. It's a typical history. you get that part in your history, you must think of the elderly part. Then you ask these things. Whether the patient has obstructive jaundice, mass coronary examination, past history or recent this episode, obstructive jaundice. Whether the patient is already diagnosed patient or recently diagnosed diabetic fever, now pancreatitis. And if you think you have a long case of chronic pancreatitis, don't wait till your past medical history towards diabetes. Ask that. That is exocrine failure. And you have to, now, let's say a patient is diabetic for 20 years, but abdominal pain for last 2 or 3 years. Very unlikely that the diabetes is due to that. So you have to ask how long it has been there for diabetes. And I told you at the same time, ask about the treatment also. Those who have chronic pancreatitis and diabetes, most of them are insulin dependent. What is the classical thing about diabetes? It's very difficult to control, brittle diabetes. I admitted a patient yesterday from the clinic. That patient was transferred to medical management. I index 600, postprandial was 600. Very difficult to manage because you can't keep them on a fixed dose of insulin because the next moment they become hypoglycemic. It's difficult to manage. Brittle diabetes, you call them brittle diabetes. And also ask about exocrine failure, weight loss and how significant was it, and also about steatoria. Steatoria, I prefer if you mention inpatient drugs.
Heart flush.
Sticky, fatty, bulky. Steatoria is the patient can have steatoria.
Difficult to flush.
So that is, then you have to think of causes. These are the presentations and effects. Then you think of causes. What are the causes? One is recurrent event. Recurrent event. Keep our having a thing. There are no hard and fast rule after how this number of episodes it becomes chronic here. So recurrent event. Any other cause? Alcohol. ඒක social history එකක් ඉන්න එපා අහන්න. ඒක අහන්න මෙතනදී අහන්න. Smoking. What else? Smoking is a factor. I don't think so. Alcohol, yes. Trauma leading to recurrent acute, not just one. Trauma, there's a stricture and then recurrent acute and lead to chronic. Okay, hypercalcemia. Leading to recurrent acute or congenital. So how do you ask congenital? Family history. Family history of patient with same problem. If you get a, let's say, a 15-year-old boy coming with chronic pancreatitis with gross calcification of the pancreas, it's very unlikely to be due to acquired cause. Most likely due to hereditary cause. It's autosomal dominant. SPINK1 gene, genetic mutation. Having said that, we have seen several hereditary pancreatitis patients. They don't have positive family history. Either this is the index case, or I family members say, I'm not applying in the mind. Autosomal dominant what I have up to Hambela. So you have to ask about family history. Especially if you are a young patient with gross calcification, you have to think of that. And there's another entity now. The pancreatitis can be due to recurrent acute ones. It can be hereditary chronic pancreatitis. They may or may not have family history and they are usually young. What is TCCP? Tropical chronic calcific pancreatitis. TCCP. Tropical chronic calcific pancreatitis. That's another entity. Usually the second or third decade, not the third or fourth decade. May age group if you find a patient who's not an alcoholic and gross calcification in our region, we are in tropics, so you can diagnose this condition with no other obvious cause. Calcification now it is alcoholic pancreatitis. Otherwise, from this other causes, alcoholic. So what are that? So in the history, you ask about alcohol. TCCP, there's no way of asking. Hereditary you ask about family history and the recurrent acute episodes. And remember, most of these patients, they know their diagnosis. Until you get it there, they know their diagnosis. IBD also the same because they are chronic diseases. Ulcerative colitis, Crohn's disease. Patient will tell you. Because it's a chronic loss, and unless you get a brand new case at the exam, if you are lucky enough, you might get a brand new case. Patient down there. आगे लॉन्ग केस के पेशेंट में बीडीएम स्ट्रीक आते हैं अगर माथे आगे कितना दर्द patient is that helpful. But in my long case, first 10 minutes for discussion, first 5 minutes examine ask if this patient developed pharyngitis, if you are in more Padu for hospital, how will you manage this patient? That is the first question. Second half, in the other end, Dr. the other consultant, he asked, your patient died following laparoscopic cholecystectomy. What will you do? Dr. Pig started aside to get the question. He asked about who should do the breaking bad news, how would you realize the inquest. So second half of that, I was frustrated, furious because they didn't ask who was here, so nothing. There are so many things to ask about. But I knew how to manage an inquest as a house officer. I knew how to proceed. Now don't go and study forensic from today. So all let come home and confirm that house officer other inquest in the card of the board the shadow period तो एक पता नहीं अब तो एक दर में वन ईयर दर में क्या था मगर सेकंड हाफ में क्या बोला उत्तर दे दिया नहीं होना nothing about those stones nothing patient merla so don't go and study forensic so those who have finished shadow period tell me how to arrange an inquest. I'm not going to ask you can anyone tell me how to arrange an inquest as a household to whom we should be informed? Do you know how to confirm that? What should be like after resuscitation failure? How long you should continue resuscitation ideally? At least 20 minutes you should continue, not less than that. If the patient shows any signs of recovery, more. Okay? Then how do you confirm the death? What you should document? No one pulse. Radio pulse. Middle pulse how is it? Did I you are not telling me here? After this over क्या है? You know Christopher? Christopher and America and Christopher. जेब में क्या कर रहा है? Christopher क्या? No, let us pardon me, anybody. Central pulse, carotid pulse, no palpable carotid pulse. Number one, anything else? No spontaneous breathing. It's dilated few ways. No heart sounds or breath sounds or auscultation. Huh? No response. Huh? What? GCS अनुमति नहीं मिलने बुलाना मानते नहीं इंजीनियर लोग दावे बोलते हैं वो बोलते हैं मैं बोलते हैं वो बोलते हैं बाप बोलते नहीं दाले लगे बुलाना बोलते नहीं ना बाबा इधर everybody? No central pulses, no fixed dilated pupil, no heart sounds or auscultation, no breath sounds or auscultation. There is no spontaneous respiration. Fine. So this will occur by so and so at on. Let's say it's a post-op death, or death within 24 hours. Can you give post-op death? We generally don't. Unless we are the treating physician for that person. So now, Ferdinand के रखने की क्या है? Terminal, ये patient में अपना हो, एक अभी other casualty है, that patient में अभी other patient में करना है. So that patient, as we know, that patient was terminal and we have been treating for that patient, we can give post-op. Otherwise, we can't. अब काला तेरा लगना चाहिए, patient में करना है, right? We can give what? Probable cause of death, and then ask for inquest. If you don't know anything, better to ask for inquest. Don't give it probable. So you ask for inquest. If you give probable, if family members are not suspicious for death, coroner can convert the probable into cause of death and give a death certificate. If you can give cause of death, who gives the death certificate? The board issues the death certificate. The person can write the death certificate. Okay. These are things like atau badan none में body barat inquest step पड़ेगा part हो जाए. Direct and not police first. Director के नाम में direct अपना to authorize to arrange an inquest. Police force, please you can have to arrange an inquest to this death. Clear? इधर पास है? विकास मोहल्ले में. Hospital police will inform closest police station to that patient's family. If they say over the phone, no, you all can go ahead with the postmortem. Nothing. Because lower patient can be lower police independent. They can do it. So they should come and then it goes to coroner. So coroner will order postmortem. If coroner can't give cause of death, if you have not given probable, coroner has to most likely give cause. Can a coroner give cause of death?
Yes.
If we have not given cause, what do you call that? If coroner has, if we have not given proper cause of death, can the coroner issue the death certificate? What do you call that? Huh? Open verdict. Open. You can give an open verdict, but then family can only bury the body. They can't cremate the body. Okay? They can't cremate the body. They have to go for postmortem and then issue this. As house officer, you should know how to arrange an inquest. So you have to write to those two parties. When there's a death in the ward, who should do the breaking barriers? Housewife. House officer. Who? Huh? The most senior person. The most senior person should do it. If not, it will not house officer. Breaking barriers करना हमें आइए कंसेंट का करना है तो ऑपरेट करना है उससे आइए क्या ऑपरेट करना है अपना मांग ऑपरेट करना है विपल लैब करना है मांग के अपने मेवा नाम इन कॉम्प्लिकेशन है मैं चला है दिस दैट 5% mortality rate not on the complication with children. So if they ask at the why wow whatever it should be done by this person ideal. Right. So coming back to pancreatitis. Otherwise, my even as a legal forensic in back now. Other key of part of the company back now, otherwise, she will be the so you have the work to buy the is not it. Buy a but while you look at it, you buy a now I have to pay with that in it. But I some very sad in it. But you want to give a take out, take it to all of the Bible carrier. not 3 millimeter. So chronic pancreatitis is now. So these are the causes. Now it's very easy history. Okay, this is a very short history. Typical scenario I have told you. Recurrent episodes requiring or not treatment as test writing. You characterize your pain. This is a typical pancreatic pain. These are the presentations. If they have these presentations, elaborate them. Don't just stop there and there. Don't wait till your pastor needs to ask diabetes. Don't wait till your family history and social history to ask about family history of alcoholism. So God said, don't ask about stroke and night. Moms. With regards to even for moms, I don't recommend to ask that. We will only give a patient with mom's second pancreatitis. So they said. Most likely you will not be given patient acute pancreatitis because they are ill. But it can be asked. Even in chronic pancreatitis patient, acute pancreatitis management can be asked. You can't say, no, this is a patient with chronic pancreatitis, how can you ask about acute pancreatitis? You can't. Even if they ask about rectal carcinoma with chronic pancreatitis, you have to answer. Yes. Faculty rules or regulations or there, you can't go to courts. You can't have that. Right? So then, so that is the history. Okay? Don't ask about those things. Moms now then because how they when a candidate moms has not, if you get mom's coitis, the students get mom's coitis, there's a possibility of subfertility. So we don't want to make you all suffer that. So don't ask. Family history of scorpion bite, come on. Because I don't write a case report. What you are doing? Clear the history? Examination generally, what do you think? Nothing. Unremarkable examination unless they are complicated with obstructive jaundice, complicated with mass formation. The abdomen, everything is unremarkable. Typically, if you go to a textbook, they will say those who have chronic pancreatitis, some of the patients they have erythema around the gastric region. But I don't think person like me or Chintaka or these guys will show any signs of erythema here. Maybe a very fair person will show. We could have someone in the world. They rub it. They rub it. Have casualty injection morphine. Can you maybe learn morphine? Because they are anesthetic abusers. So it's them and recurrent ability. So that is called erythema. Erythema
Yes.
But if you read a textbook, igname is probably ignite means so but I am yet to see a patient like that. So I don't mind even if you don't mention this patient does not have but somebody asks, yes, this is one of the sign. Positive side can out in a way. I never know unless they are complicated. Okay, investigation. How do you investigate a patient with pancreatitis? Chronic pancreatitis. Remember, the long case, this will be discussed as what? Abdominal pain case. So it will be initially presenting as epigastric pain. So your discussion can be totally what? Acute pancreatitis. Remember that. Mana can win. देखो मैं कटेगा ना केस देना वो आगे डिस्कशनिंग होके जाएगी तब investigations? What are the investigations? I'm not discussing about patient, how to investigate a patient with epigastric pain, that we have discussed already. I told you on that day, ECG, chest X-ray, and MRI is the initial investigation. Once you make the diagnosis, then I told you set up investigations. Let's say for money, if you have a diagnosed patient with pancreatitis, what are the methods to diagnose? What is the preliminary investigation that you can do? The most preliminary investigation. ऑनलाइन पे करके हमने चार्ज करते हैं और आप को ना पे कर abdominal X-ray. What do you see? Pancreatic calcification. Any other investigation? Ultrasound abdomen? Yeah, sometimes you can see pancreatic calcification. Anything else? Complications, a mass or a cyst or whatever. You can do ultrasound. Especially if the patient has cirrhosis, that's a very sensitive investigation. Some especially related cirrhosis. Anything else? CEC, contrast enhanced CT scan, abdomen, pancreatic protocol.
So what is exactly meant by pancreatic protocol?
There are several protocols. It depends on the phase that they take. Late arterial, early arterial, there are phases. The pancreatic protocol also there are phases. Early arterial phase, and the cuts. 3 mm cuts, 2 mm cuts, cuts there are levels. There are arterial protocols, there are pancreatic protocols, there are hepatic protocols. You all don't need to know that much, but it is something to do with the radiologists. When you ask for pancreatic protocol, they do that first. If you just ask for abdominal CT, they will do abdominal CT. So what are the things that you can detect in pancreatic protocol CT or CT in abdomen? So see the pancreatic evidence of pancreatitis. You will see calcification. Now earlier days they divide the calcification to 2 things: ductal calcification and parenchyma. There is nothing called parenchyma calcification anymore. It's a regular alcohol equivalent parenchyma calcification, TCCP and ductal calcification. There is nothing like that. What you see as parenchyma calcification is the branch duct calcification. Branch ducts are the area of the parenchyma. So all are ductal calcifications. Okay? All are ductal calcifications. And also it gives additional information. If there is pancreatic neoplasm, it will also show the pancreatic neoplasm. If there are cirrhosis, it will also show that. So that is that. If you want to see the ductal pathology, what is the investigation? Let's say to see whether the duct is dilated or intraductal calculus. When you have MRC, that gives additional information or more accurate information of the duct. The degree of duct dilatation, intraductal calculi, all these things. And if there is a cirrhosis, whether it has a communication with the pancreatic duct. That will also be shown in this. Okay. If there is cirrhosis, whether it has a communication with the duct. MRC. Even CT says, but this is more accurate than a CT to see the ductal anomalies. So these are the investigations. Other than that, what are the other supplements? These are all to diagnose Evidence of pancreatitis. Don't see the complication. Anything else? Additional supplementary investigations? Fasting culture. Or even HbA1c. You can do LNPs. Yes. LNP. Because whether that will be patient obstructive jaundice nectar, but I don't know. Albumin. Chronic weight loss है आप nutrition भी patient के exercise पे जाते हैं ना patient losing weight. Patient can be hyperalbumin. LFT, the total profile is important in the patient obstructive jaundice, but here albumin to assess the nutritional status. These are the other supplementary investigations. To diagnose steatoria, the ideal test is fecal fat excretion or fecal elastase test, which we don't do. Fecal fat excretion or fecal elastase. We don't know those investigations. These are investigations. How do you treat these patients? Current in after on this pain. We have to manage the complication. Hydration. Endocrine. So fine. But it's not managed happening. Okay. There's a framing course, you can treat the course. Pain. So basically the 4 points are these things. Right? Pain. For pain management. What kind of pain is it? So chronic pain. Chronic pain. So with regards to analgesic ladder, climb up the ladder. Start with small ones, then you go up, and you can also consider multimodal analgesia. So before we come to analgesics and the other factors, they have to avoid alcohol 100%, smoking 100%. Right? So you have to. They should be given nicotine replacement. They can be referred to, help centers like Med7 to stop alcohol. Because with this, there is no place for management of pain, and you can't manage their pain if the confounding factor is still there. Some people they can't stop alcohol, so you have to refer them to relevant parties to get rid of it. So they need a lot of psychological support. One thing is they have to tolerate the pain to a certain extent. It cannot, you have to tell them this cannot be totally cured, this disease. You got to live with it. They need psychological support. They need psychological support, stop alcohol, smoking, and then the pharmacological drugs, analgesics. So there you mentioned about the WHO ladder, you climb up the ladder, and about multimodal analgesia. You mentioned all these things. What else? Anything else to manage pain? To manage pain?
There's obstruction.
Yes, if the patient has ductal obstruction, you got to relieve the obstruction because we assume this pain is due to intraductal hydration. So we discuss about acute complication. Yes. Endotherapy or surgery to relieve ductal obstruction. That is also part of management of pain. Anything else? What is the nerve supply of the pancreas? Celiac plexus. Celiac plexus. So you can do celiac plexus ablation, either ultrasound guided or even open or laparoscopic ablation of the celiac axis with what? very far. You can apply it with bupivacaine, but it's not that long last. You can apply it with 100% alcohol. Alcohol or phenol. Phenol also can be given. So generally we use bupivacaine or alcohol ablation of celiac cancer. But again, the pain recurs. Sometimes the action lasts for about 3 to 6 months. Again, the pain can recur. Another way is doing a scratch nectomies. Those things are rarely practiced. Celiac actis block and the scratch nectomies are rarely practiced, especially scratch nectomies. So commonly, the most important things are the avoidance of alcohol and smoking and the drugs. Management of endocrine failure. Particularly refer to endocrinologist. But at the exam, also in the surgery, you can tell, I will liaise with the endocrine team and manage diabetes, and the diabetic control is very difficult because they have with diabetes. You can say like that. But if you get a medicine diabetic case, don't say I will refer to diabetes. The diabetes is a wrong case. I am referring to I will refer you to next exam. Surgery you can get away. I will liaise with my endocrinologist team because it's diabetic control is difficult to control. Very easy answer. Exopine failure. Or the management of nutrition. So those who have significant loss of weight and steatoria, they need enzyme supplements. So again, management of nutrition, whose help you can get? Nutrition. Whenever possible, you get some. It's a multidisciplinary management. There also you can get the management pain team. Pain team anesthesia pain team. They are painful sometimes. When they don't give anesthesia, when they postpone cases, they have pain in the ass. So we can refer the patient to pain teams. If there are pain teams, we don't have a pain team. We have a pain team here. There are pain clinics. NHS says there's a pain clinic. There's a pain clinic, so you can refer to that, especially for axis block, celiac axis block. You refer to that. They do it. Good at it. Exopine failure also you can discuss with your nutritionist to manage that. Basically, you have to replace what? Enzymes. So how do we give enzymes? Prion is a trade name. We cannot. For some certain things we can use trade names. There is a one called pancreatitis which we don't have, but we currently have it. Prion. You can tell that exam, but say it's a trade name. Enzyme combination. Currently we are using the drug called prion, which is a trade name. So depending on the degree of weight loss, depending on the degree of steatoria, you can replace them. The dose depends. There are doses 10,000 units, 25,000 units, 40,000 units. General recommendation is to give a full dose with all 3 main meals and half dose with 2 snacks. Main meals have full dose. Let's say patient has lost a lot of weight and steatoria, you can give 40,000 straight away. 40,000 with all 3 meals and another 20,000 with 2 snacks. Sri Lankan population, they don't eat snacks. The proper snacks contain so we generally recommend 3 meals. There are 2 types of preparation, enteric coated and enteric uncoated. So whatever it is, they have to take the first out of the meal. And this goes to the stomach first, and then pancreatic enzymes are inhibited by gastric juice. So therefore you have to give PPI, proton pump inhibitors with pancreatic enzymes, otherwise your enzyme is going to be deactivated inside the stomach. So generally we combine the pancreatic enzyme replacement with proton pump inhibitors. to suppress the gastric acidity. Some of the preparation they also have selenium. Selenium also has effect on pain relief. So that is the management of exocrine failure, replacement of pancreatic enzymes, and they get the help of nutrients. Then the other one, management of complications of pancreatitis. So complications can be, when the complications, one is intraductal, now ductal obstruction. Any other complication? Can you see it? Anything else? What? That's it. Cirrhosis. Anything else? No, not a gastric obstruction. Especially the calcification mass. Calcification mass sometimes cause gastric obstruction. And obstructive jaundice. Abscesses. Acute pancreatitis, yes. Ductal obstruction. So in these patients, if there is ductal obstruction, we assume that the pain is due to this. How to diagnose ductal obstruction? By CT or MRCP to show dilated duct. It could be due to stone. It could be due to stone. It could be due to stricture. It could be due to stricture. Sometimes because of stones there are strictures. Stricture causing obstruction or stones causing obstruction. Sometimes because of the ductal obstruction, the distal duct ruptures. Distal duct ruptures. They come with pancreatic ascites. Sometimes we have patients come with pleural effusions. Special left side. Pancreatic pleural fistula. Right? We recently had a patient. Rare, but pancreatic pleural fistula. Those with chronic pancreatitis with ductal obstruction and duct ruptures, it tracks around along this region in the pleura. Because that has defects. Pleural peritoneal membrane. Some other defects they have. Okay, for example, those are rare, very rare concentrations. Okay. Pancreatic ascites is commoner than pancreatic pleural fistula. So ductal obstructions. What are the ways to manage these ductal obstructions? Yes. If it's a stricture, you can do ERCP and pancreatic duct stenting. But sometimes the stone burden is huge, where you can't straight away pass on guide. You can't guide poison. If it's a one large calculus at the head, you can try ESW. Extracorporeal shock wave lithotripsy, break the stones, and then try ERCP and stenting. But if the patient has massive calcification, somehow calcification those patients are not amenable for this ESW because the stone burden is huge. When the stone burden is small, like single or one or two calculi in the head, you can try ESW. But if there are multiple stones in the head, ESW is not an option. There you have to consider surgery. Surgery is pancreatic jejunectomy. You can also call Versam jejunectomy. Versam means duct of Versam, major duct of Versam. My ducting number? So major duct of Versam can come surgery, Versam. Or else you can say pancreatic jejunectomy. If there are calcification in the head, you can just go out the head. You can do pancreatic jejunectomy with head coring. Mention to the Ramanda Ibrahim. May I have a more question from my guest? If I get a So these are the options available. But MCQs are not very common. These are the options to sample options. We have another. Those who have pancreatic division causing pancreatitis. I told you, when there's no obvious cause for chronic pancreatitis or acute pancreatitis, we do MRCP to identify any anomalies. Pancreatic division means mild. You know what pancreatic division means?
Yes. Ventral bud and dorsal bud. Ventral bud එක dorsal bud එක එකට ඇවිල්ලා body පැත්තේ two bodies ventral bud.
Major are open through the minor papilla. There are so many variations, but mainly it's major are placed through the minor papilla. So large amount of output trying to come to a small opening. That is the reason for back pressure and overactivation. So how do you treat? You do a sphincterotomy of the minor papilla. So if the diagnosis is pancreatic division, the best investigation diagnosis division is MRCP. If you diagnose that, patient needs minor papilla sphincterotomy as stenting. There's a patient called Anuda Kumar, female ward, whose patient that one? Your. Yeah. So that patient is pancreatic division, and we have done pancreatic minor papilla sphincterotomy as stenting.
ये patient बात करें.
That is that. So that is the after option. Pancreatic carcinoma, because chronic pancreatitis is a risk factor for pancreatic carcinoma. So if they get carcinoma, I'm not going to discuss management. It depends on the site. They can get carcinoma at the head, body, or tail. Which one has best prognosis out of the three? Head. Head. Why? Presentation early. If it's a body tumor or tail tumor, they present quite late because symptoms are either way, arthritic obstructive jaundice present now. Unless you detect the body or tail tumor by a routine CT scan, medical level CT scanning, the presentation is very, very late. So I'm not going to discuss management, it depends on the site. And pancreatic CA carries a very poor prognosis compared to other malignancies. Even after curative resection, 5 years survival is less than 40%. Even after curative resection. So obstructive jaundice is another complication. Obstructive jaundice can be due to malignant transformation of the chronic pancreatitis or even calcification itself. Sometimes I told you they can have entire calcified head. So even calcification itself can cause obstructive jaundice. So what is the treatment? If it's a malignancy, I am not going to discuss. If it's a calcification for obstructive jaundice, ERCP and stenting. So that is obstructive jaundice. Gastric ductal obstruction. Even without malignancy, sometimes it can give us to gastric ductal obstruction. You can do actual bypass surgery. Bypass surgery. Pseudocyst. Another important, you can just short note, write a short note on pancreatic pseudocyst. Pancreatic pseudocyst. Including Kushani, Mitul.
Membrane එක ඇත්තම
has a wall, but
not proper.
no epithelial lining. No epithelial lining. That's why it was pseudocyst. What are the causes of cirrhosis? Sorry, pancreatitis. Acute pancreatitis. Sure. Did you call it cirrhosis or acute pancreatitis? After 4 weeks. Before that, you call it acute fluid collection only. Presentation? Clinical presentation? It can be pain. It can be due to pain. Yes. Obstruction or pressure effect. Pressure effects tamam है pain tamam है. Infection. Rupture. Bleed. So they can present any of these ways. So due to pressure effect can cause pain. Okay. Infection can cause pancreatic abscess even. Infected cirrhosis lead to abscess. Not a pancreatic abscess, we call it an infected cirrhosis. Infected cirrhosis. Rupture. Obstruction. The other one is obstruction. It can cause gastric outlet obstruction, duodenal obstruction, small bowel obstruction. That is also part of pressure effect. Where can it rupture? Peritoneum. It can rupture in peritoneum. Right? So think pancreatic, the size. It can rupture into retroperitoneum. Then track around psoas muscle. That psoas collection rupture. Track around the psoas muscle. Track around the psoas muscle. Retroperitoneum rupture. How about rupture? Can rupture in the GI tract. So maybe undiagnosed. How about rupture? Can you rupture to blood vessel? Yeah. And also there is a bleeding if you rupture in the blood vessel, so there is a bleeding into the cyst. Patient in complete pain. Or ductal connection and pseudocyst ductal connection and pseudocyst blood vessel is rupture होगा bleeding through the apparatus. Then one patient in male ward has got hemophilia. He's bleeding through the biliary tree. You can arrest it. Only option is angioplasty, like it was failed. Not done. So, this what you call this. I now remember spelling school. Hemosuccus pancreaticus. Let's find out this. Hemosuccus pancreaticus. Rare complication, but deadly. Yeah. Maybe in MCQs you can get it. Hemosuccus pancreaticus. So this is the clinical presentation. It can cause pressure effects, pain, can cause obstruction of the GI tract, it can cause infection, rupture, bleeding. So those are the clinical presentation. So it can be totally asymptomatic. Just having mass, no cirrhosis, multiple cirrhosis, but totally asymptomatic. Investigations. How do you investigate? Ultrasound is very sensitive. You can do ultrasound. But if there is a diagnostic doubt, you can go for a CT. Only if there is a diagnostic doubt, we go for the CT. What is the diagnostic doubt? What type? Cystic malignancy. You are doubtful about cystic malignancy. If you are doubtful about cystic malignancy, we go for a CT. Otherwise, a known patient, a patient who had acute pancreatitis, or known patient with pancreatitis, or a patient with pancreatic trauma, if ultrasound says it's cirrhosis, it's actually cirrhosis. If ultrasound says no, I am doubtful, especially because cirrhosis do not have a septate. Septate है, बहुत है, enhancements and moves there. Isn't there? Alpha enhancement pin there. There move there. If the ultrasound is doubtful, then you have to go for CT because if CO says it is doubtful of cystic neoplasm, then next investigation is CT. So there are so many cystic neoplasms in the pancreas. You will need to know a lot about this. I tell you a few names. Serous cyst adenoma is one. Right. Characteristic appearance is bunch of grapes or honeycomb appearance. Whose patient is pushed by your patient? So you know the surgery? No. Who was there for surgery? Pushpa surgery? This current medical one Takara Yanni को last year थी ना ये तो ये आती है. Global volume में सब का मिल गया. This is the system. What is it look like? Bunch of grapes. This is essentially benign. And this is common name, elderly group. This is called, we generally call grandmother cyst. We'll make it an architect. Then next one is MCD, mucinous cyst neoplasm. This is pre-marital. If you diagnose this, patient needs surgery. Serous cyst adenoma, if they are symptomatic, we do surgery. If they are asymptomatic, follow them. Mucinous adenoma, if you diagnose MCN, we do surgery. This is usually in the reproductive age group female. So it's called mother's cyst. I think the other one is IPM. Even if you forget these things, I don't mind. Intradactyl papillary mucinous neoplasm. This happens within the pancreatic duct. This is common in both age, young age group, in both males and females. These are common among females. IPM. One is daughter cyst, the other one is mother cyst, the other one is grandmother cyst. So you have bicycle again and another one. There are so many other things. So these are, if you are doubtful of pancreatic cystic neoplasms, then patient is CT, otherwise ultrasound is sensitive enough to diagnose cirrhosis. If CT says it is neoplasm, we got to differentiate whether it's SCN, MCN or IPMN, then patient needs guided aspiration. And then you can differentiate. I'm not going to tell you how to differentiate because that is not relevant for you all. So if you suspect this, patient needs guided aspiration and send that sample for CEA and MIS and MUC. Then you can differentiate between cirrhosis, MCN and SCN and IPMN. Send that sample for those things. Guided aspiration. So that's how we investigate a patient with cirrhosis. Ultrasound is sensitive enough. Sometimes we do MRC just to see whether it has a connection between the main pancreatic duct. Because most of the cysts at the beginning they have a connection, but with time they loses their connection with the duct. Then treatment. If they are asymptomatic, treatment is nothing. Don't trouble the trouble until trouble troubles you. That principle. Right? Don't do anything. Good old days, if it is more than 6 centimeters, you've got to do something here. Then there is no size cut off. If they are asymptomatic, don't do anything. Let it be. But if they are big, most likely they are symptomatic. If they are symptomatic, you have to treat. So what are the treatment options available? Percutaneous aspiration. Is it a good one? But it's a problem as well. So you are creating a pancreatitis fistula. It is also an option, but we don't do it because Clinically, outcomes are not that good. Subcutaneous aspiration, not a very good option, not a very popular option. Good करना कमाई करता है. Drain into the closest viscera. Drain into the, if it is close to the usual pancreas is in the stomach bed. So if they develop cyst, most likely they are in the lesser sand, bulging into the stomach. So you can do a cystogastrostomy. Cystogastrostomy. Gastrostomy. If it is close to the duodenum, you can do cystoduodenostomy, cystojejunectomy. So close, drain into the closest viscera is another option. That can be done several ways. Let's say cystogastrostomy. It can be done endoscopically, laparoscopically. When you put the endoscope, if you see a bulge, a huge bulge in the posterior wall of the stomach, we can do endoscopic ultrasound scan to confirm, and then pass a needle into that, then dilate the blood, put a stent. So all the cysts to it will drain into the stomach. So that's why endoscopic cystectomy. Or you can do open surgery and drain into the stomach. Now, cystoid will come into the stomach, but the camera and then all the other काफी लोग को ना से एक और करना है क्या तेरा तो बारो कैमरा लोग को बात ही यार ये मेरे ने अनिक तो बोला है so endoscopic cystogastrostomy or laparoscopic or open cystogastrostomy on gastrostomy it can be closest viscera duodenectomy jejunectomy any other option those who have connection with the pancreatic duct if we do a pancreatic duct stenting that also facilitates drainage. That also facilitates. That is called transpapillary drainage. This is called papilla. Transpapillary drainage. So these are the options available to manage the pseudocyst. Asymptomatic do nothing. Symptomatic do one of this. Sometimes they don't have pain actually, they're just asking for that, so you can try a trial of distilled water. Sometimes we do that also. But we can't say distilled water in front of, we say DW. But those patients, they know what DW also. Or DW, they know, because they're that chronic. Mana ini beberapa pembela mal kayak orang di dalam baru kira bilau. Bilau main salah lagi. Di situ dia ambil tidak lupa saya lagi.
Oke, mana itu kumbala ada sih? Mana itu kumbala ada sih?
Kumbala
kanan sama kanan.
See, this is suspicion of usage. Serious cystic neoplasm. Yeah, your patient has serious cystic neoplasm. We could have not done surgery. That's your argument. Lung and epigastric discomfort. And the other thing is, she's not that symptomatic. When we discussed that at MBBS, they were not very sure about the diagnosis of serious cystic. Because serious cystic neoplasm, as I told you, it's a disease in the latter part, grandmother cyst. Plus, the cyst was so big, if we wait for another, let's say, couple of years, we might not be able to do surgery. Although it is benign condition, sometimes we can't operate. Cystic operate now we took that decision. How about recover? Okay, cystic adenoma, तो इधर से मैं थोड़ी देर बाद आपको फिर you can't do that. I agree with you because there is no real indication for surgery. That's why we tried our best to not to do whippers, but to finished with the central pancreatitis. Right. So clear? Management of cirrhosis. Any questions over chronic pancreatitis? Any questions? Hypocalcemia chronically. Those who are having hypercalcemia can get chronic pancreatitis. We had several patients. So one patient had pancreatitis, stone disease, and found to have parathyroid adenoma. Yeah. Seed. Aspiration. It doesn't. Theoretical. Because we are doing a fine needle aspiration. The malignant seeding with fine aspiration is negligible. There are certain tumors we don't do. Parotid, there is a chance of seeding. That's why we don't do true cut biopsies. Appendices can be done. Renal also we try our best to try our maximum not to do a biopsy because there are reported cases of tumor seeding. When you discuss with registry, they will tell you what are the indications to biopsy for renal management. There are certain tumors there's a risk of seeding. We don't do, but pancreas we do. If it has obvious features of malignancy, we can operate. We don't have to do it. Because pancreatic malignancy is one malignancy we can treat without having histology. Generally, to treat a malignancy, we need to have a prior histology. We can never treat a breast carcinoma without histology or histologically proven malignancy of breast. Prostate, same. Right? Colorectal, same. Esophageal, same. But there are certain malignancies, pancreatic, cholangio, brain, renal. We can treat them without having biopsy to work because imaging evidence is enough. Imaging and clinical data is enough for us to go ahead with. But if you are planning neoadjuvant, I told you what is the definition of neoadjuvant? Any treatment given prior to surgery, prior to definitive treatment. Correct? Is totally proven. So if you are planning neoadjuvant, they need then only we have practiced. Otherwise, cholangios can be treated without. Most of the people's patients, they don't have prior histology. Because pancreatic, distal cholangio, periampel, they do have histology. Because there's a growth, we can take biopsies. Otherwise, we don't need to have histology. We go by clinical and imaging evidence. Pancreas also same. Because pancreatic CA occurs mostly in the background of chronic pancreatitis. If we get a histology by FNAC with endoscopic ultrasound scan, the chance of getting a representative sample is the incidence is low. Let's say it becomes negative. Can we exclude malignancy? But if we have not taken the biopsy from the correct place, because in a chronic pancreatitis there is a significant element of fibrosis. If you don't take it from the correct place, you are going to miss the malignancy. So that's one way you can tell the patient. It's a major surgery that there's a chance that your histology can become benign. Make a make an arteria novenal pull. You make the current node. That's an arteria pull. Make a current option. But if it is serious, if you can confirm it's serious adenoma, you can follow that up. But you serious, you have to. You consider, you have to tell the patient. But mucinous cyst neoplasm of an 8-year-old RC, we will not do it. Because a mucinous is a malignant phenomenon, there's a time period for transformation also. Pseudocyst. If you aspirate it, amylase levels are high. Aspirate fluid amylase levels are high. obviously yes. But there are, I can't tell you the exact figure. There are certain things very doubtful. Then we give the benefit of doubt to the patient. Because all these pancreatic surgeries are major surgeries, major complex surgeries. So lot of morbidity and mortality. Because we were not sure at the discussion, we didn't want to take a chance. Because now it's operable. If we wait for another couple of years and if we become inoperable, it's a waste of life. And it's very big. It's about 8 to 10 centimeter size. Our topic was like here, our operation very good. अपराधे मेडिसिन से खबर है जरा पासे हॉस्पिटल में ना अपराध एक कार्य कराना बेटा आपको क्लियर because all these are borderline because we are removing there's a risk of malignancy. So when if you remove it when it is not malignant, life expectancy becomes unless they develop post-operative complication and die, they become normal people. But if they develop malignancy even after curative resection, their 5 years survival is less than 40%. Pancreatic malignancies are like that. Take it along. It's a very difficult discussion with the patient. Patient again. Just tell me complications of splenectomy. Now it's a homework time. Bala lagi ya? Enggak malah lagi ya?
As in other surgeries, bleeding.
How do you classify it? When you are finally mental student, surgery,
Immediate complications.
there are immediate complications.
Early complications.
Early and
Yes.
regular. Immediate, so what are the immediate complications? We forget about the acid complications. We will want surgical complications. There's another way of classifying it. Post-surgical complications, anesthetic and surgical. Surgical can be immediate, early or late. Right? What are the immediate complications?
Hemorrhage due to seepage.
What do you call that hemorrhage?
Waste.
How do you classify hemorrhage? Primary hemorrhage. But you understand the primary hemorrhage? Before sedation, leave the theatre. Before leave the theatre. What are the causes of primary hemorrhage? What are the causes of primary hemorrhage? पूरा प्लेयर को हमने दरिया को बहुत डैमेज कर दिया। स्लीप फाइबर में नहीं, स्लीप फाइबर तो स्लीप फाइबर में नहीं है। So there is a possibility of damage in understand. So cardio, sleep weight and surgical procedure is not the question. Primary hemorrhage. Any other complication? Immediate complication?
Medicine.
What did you expect? What did you refer? You can take a Nobody does it better. What was the side? What was the side?
Braces.
Medscape should have better. Medscape is a very good device. Now come back to this. Don't go back. Back in this land, not in America. Yeah. Don't say don't search that side.
Pancreatitis due to damage to the
How will we classify? Right. What are the immediate complications? What was the next? What will we read?
maybe or deep.
Behavior. Huh?
කවද්ද මේ දුන්නේ? හා?
Yeah, whether I need it or not. What are the key? Sleep like it is not primary. Primary means is at the time of surgery. Maybe because of surgery is clumsy or the sleep is too weak, so they could tie up the splenic hilum. So, local surgical procedure के लिए करता splenic hilum में clamp करना करें, splenic का दुआ लगा. तब तावस में splenic कैसा पैर में तावस में होता है?
Very short test.
पंद्रह रिकमेंड है.
Gastrospasm. Spasm. Gastrospasm.
नंदा. Very suspicious. Your group is exceptional. But a different context. So, gastrosplenic ligament का ना short gastric है. There are minimum of 6 more or more. So short gastric, bleeding from short gastric, bleeding from splenic hilum, right? Those are the causes of primary hemorrhage. Or it could be retroperitoneal vessels. Because you are tremendous way or ligament ligament and so there are two ligaments, ligament and gastrosplenic ligament. Gastrosplenic ligament, short gastric. Why do you call them short gastric?
There are long gastric acids.
That's short. So that's short, very short, very difficult time. These surgeons again another area that we respect. Another area that we क्या होना कोहटा रिट्रैक्ट करना इधर से ब्लीड करना अत्र करना है. We respect short gastrics also. Like we respect.
Yeah, Tejan said you were. Tejan said you don't touch that thing. Yeah, don't touch that.
Women and pancreas. Quality is very. So hemorrhage, primary hemorrhage from either pedicle or from short gastric or from retroperitoneal. Any other immediate complication? Damage to surrounding structures. One is tail of the pancreas. Anything else? Fundus of the stomach. Specific. Fundus of the stomach. Anything else? What damage to the
Kidney.
Okay.
Kidney, sir.
Generally no, because it's retroperitoneal. Anything else?
Lungs,
No, it will be very, very clumsy.
blood vessel,
No, that is not because of division. Splenic pressure of the colon. मतलब पीड़ा हुआ तो फ्रीकोकोलिक लिगामेंट का रैपिड कैलिबर नहीं है. Splenic pressure of फ्रीकोकोलिक लिगामेंट का ना एक बोलता हूँ स्प्लिनिक का रेस्ट्रेंट. Anatomy. You can't forget your anatomy.
Left colon.
Okay, you can damage. Generally, common two things are tail of the pancreas because tail of the pancreas is in the ligament. Towards the splenic hilum. And then the fundus of the stomach, especially when you try to take the short gastric vessels, and then you can really damage the diaphragm and also the splenic vessels. So that's another immediate complication. Anything else? Immediate complication? So basically those two. Early complication. then we 48 hours. Hemorrhage, or hemorrhage, reaction hemorrhage due to sleep ligatures. හොඳට ගැටකලා යනවා කැමරක ඔය ඉඳාගෙන යනවා ligation slip වෙනවා. Especially laparoscopectomy ligate කරන්නේ slip එකක් ගන්නවා. slip කරනවා. Reaction hemorrhage. මොනවා තිබුණාද කොහොමද? මොනවා තිබුණාද? ඉන්ටර්නෙට් එක. ඊට පස්සේ ඉන්ටර්නෙට් එක වලුත් I need to know the site also. ඒව වල සයිට් එක. සයිට් එක මදාරි කරලා පළි සයිට් එක මට එපා. ඒ සයිට් එක. මන්තන් ගෝලිය මොකක් තවෙක බලපන් ගන්න. That is considered of damage because you dissect under the diaphragm, so there's possibility of subdiaphragmatic collection and diaphragm splinting. So when the diaphragm doesn't move properly, there is atelectasis of the lower zone. So left lower zone atelectasis. So another one is left lower zone pneumonia. If you don't treat the patient, give the patient do physiotherapy, analgesics, patient will left lower zone pneumonia because anyway it's atelectatic. And left side diaphragmatic collections. Another one. Acute gastric dilatation is another one. Hematomesis could be yes. Especially if you damage the fundus. Not very common.
Dilatation.
Left lower zone atelectasis, left lower zone pneumonia, left sarcoidic collection, acute gastric dilatation, reaction with bleeding, all these are early complications. Late complications. And the other early complications are if you diagnose, if you damage surrounding structures, and if you don't detect it intraoperatively, they can present as fistula, gastric fistula and pancreatic fistula. That is, if you diagnose it intraoperatively, then you can do something. You can suture the stomach, you can suture the tail of the pancreas. But if you don't detect it, they can present as in the early period as gastric and pancreatic fistula. Those are also early complications. Late complications are what? Infection. What infection? What is called opsis? What is opsis? Huh? Overwhelming post-splenectomy infections. Overwhelming can be. I am also overwhelmed by your activities. Overwhelmed. When I look at you, overwhelmed. Because the effects are very disastrous. Very rare complication but fatal. Overwhelming post-toxic. Any other complications? You said thrombocytosis. Yes. Thrombocytosis. Another complication. That's why we monitor platelet level after splenectomy. So we monitor maybe every third day or fourth day until it goes to maximum and start dropping it. It goes to maximum. When we start dropping, it doesn't go back again. If it goes more than 1000 into 10 to the power 3, then patient should be started on aspirin. अब ये तो 500 निकल अब 500 drop को नहीं क्या? है इधर से आपका वेरी मैं 500 है से एक पास आपको गाना और 80 है Yeah, then you will start. So that is thrombocytopenia. And you are ligating splenic vein. So there's a chance of what? Splenic vein thrombosis. That's also another sign. Those are the late complications. To prevent oxy, we do several things. What do we do? Prophylactically, we vaccinate the patient with three. We discuss on that day what are three, and plus the influenza vaccine. And also we give them penicillin prophylaxis at least for 2 years. Those who are immunocompromised, lifelong. Out of the vaccine, which one need to be boosted? The vaccine is boosted. Pneumococcal has to be boosted every 5 years. Influenza viral vaccine every year. Whereas heat and meningococcal just once. Post-external complications. So very commonly asked viva question. So it can be a short note. Very common. I will see the patient today. Admission? Possibly. Possibly. I have to see the patient. Any questions for chronic pancreatitis or even post-pancreatic complications? Generally, after splenectomy, we keep the patient, keep the NG for about 24 hours. That is because of the acute gastric dilation. They start vomiting. What are the indications for it? How can you classify that? Emergency and electric. Emergency is your trauma. Generally, grade 4, 5, or those who are unstable due to splenic injury. Irrespective of the grade, you have to do splenectomy. Sometimes, when you open up, if you think the spleen can be conserved, you try to conserve the spleen. Because spleen is an important organ. If you can conserve the spleen without risking the life, you try to conserve. So you can do splenography, you mesh, rapid mesh, or even with a omentoplasty. You can suture the spleen. It's difficult. All these procedures are difficult. So you can do preservation procedures. You can suture them, you can do splenography, omentoplasty, all these things. And as I told you on that day, those are when stable, but HB dropping, you can try embolization. Okay? So that is about emergency spleen. What are the indications with elective splenectomy?
It is.
Yeah, hematological disorders like erythrocytosis. Anything else?
ITP.
Huh?
ITP. ITP.
ITP, yes, good. ITP.
Hematological disease. Hematological disease.
Erythrocytosis. Massive splenomegaly because they are liable to trauma, yes. Massive spleen, not absolute indication, but yeah. Anything else? Anything else? Huh? Yeah, we do remove the spleen for other malignancies. Combination with other cells. For example, distal pancreatitis. Sometimes for a malignant tumor that is distal pancreas, we don't conserve the spleen. So we have to remove the spleen with other organs In this pancreatitis, sometimes even with total gastrectomy, with lymphadenectomy, we have to remove the spleen. Sometimes, not always, sometimes.
Yes, please.
Another
Explain it, like usually in blood.
Any other
Not today, not
stool
professionally.
capsules?
What?
Yes, you can't just raise that. Maybe a large splenic cyst, symptomatic large splenic cyst, symptomatic. So other implications was to make them.
So what's in block retention? That's what we meant in the.
Unlock.
Yeah.
You call it unlock. EN unlock. Unlock means you remove everything together. Like for example, mastectomy unlock axillary. කියන්නේ අපි dissect කරලා වෙන් කරන්නේ නැහැ specimen එක ඔක්කොම එක වෙනවා. EN is on. Any questions?
I think the student can learn the speed right